So just by the fact that you're listening in on today's talk, I'm presuming that you've been giving some attention to what's happening with global health funding this year. This is perhaps most graphically illustrated by Elon Musk's express commitment to feed USAID into the wood chipper, and then his delivery on that promise. Uh, let's see here now. Okay, so what's the bigger picture for funding in global health? So as you see here, it increased quite significantly over the Millennium Development Goals era, like from about 2000 through 2013. And altogether, there was a tripling in funding. And these are constant value dollars. So these are inflation adjusted. So this is a real increase and a significant one. Then since about 2013, it kind of plateaued, except during the period of, the acute period of the COVID pandemic, there was a big uptick in funding. And that's reflected down here in this dark purple, which is infectious diseases. So especially there in 2021, this was moving all these vaccines out. But since then, what we've seen is a return to the level of funding that we had prior to COVID. And in 2024, we were back to essentially the same level of funding for global health. Now, this is development assistance. This is external assistance for health. But by 2024, we were back to the same level that we'd had in 2019. This year, though, we've seen quite a substantial reduction. So, once all of the kind of dust is settled and they've reckoned all the accounting, it's going to be in the range of 20 to 25% lower than it was last year. Now, by the way, that $50 billion, to put that into perspective, that's about 5% of what the US spends on military every year. So, it's I guess everything is kind of relative. We were just talking about Elon Musk and his $1 trillion. I guess by comparison to that, 50 billion is pretty small change. This is okay. So this previous slide is showing what the distribution is across different program areas. So you see this in dark blue up here. This is HIV. Newborn and child health is another fairly big item here in light blue. And we'll be looking in more detail in some of the later slides at funding for specific program areas. Here, it's the same overall figures, but divided out by source of funds. And in 2023, so that's here. We had essentially the same picture that we had previously. Like what's in yellow down here at the bottom is the contribution from the US government. Now, on a per capita basis, the US doesn't put very much into development assistance, but because it's such a huge country, US government's been by far the biggest funder of global health activities. So after USAID, in 2023, the next biggest funder was the Gates Foundation, then the German government, the British government, the World Bank, and France. But again, as you see here, for 2025, we see a marked reduction. So where we're getting back to funding levels that we were seeing maybe 15 years ago. So here I'm showing the evolution of funding up to 2025 and then on beyond that. Now then these numbers that I've got here for 23, 24, and 25 come from the Institute for Health Metrics and Evaluation in Seattle. Now there's different organizations that kind of reckon up healthcare spending and development assistance funding for health. IHME is one of the prominent ones, but WHO does also. But the way they reckon these numbers, it differs a bit between organizations. So you may see some slightly different numbers from other sources. The numbers I've got in the right column for 2026 and beyond, these are kind of speculative, but I've got sources for all of these, but it's I mean, at this point, I mean, there's been indications from various of the donors about their spending intentions, but until those future years come up, we won't know for sure how much is going to be spent. Um, so I mean, here what we've got listed is, I mean, Gates Foundation is a different category. The others here are all countries. U.S., Britain, Germany, and France are the four biggest donor countries for global health. The other one that fits in there is Japan, but I haven't included Japan. Most of Japan's support in global health is for infrastructure rather than programmatic, so it's a somewhat different kind of support. And I put Canada up here for comparison, and Canada is normally among the top 8 donor countries. So what we see here is, U.S. government in 23-24 spent about $14 billion each of those 2 years for global health. And then this year, I mean, this dropped by about 2/3. And the White House budget proposal for next year, proposes to further cut that amount. For Britain also, I mean, Britain previously had committed to target 0.7% of their gross national income for development assistance. And then a few years back, that was cut back to 0.5, and then just this year it was cut back to 0.3. And so these are the latest figures. So we're looking at for this year about 1.2 billion. So now that's in relative terms, that reduction is almost as big as what we've seen in the United States. Like the cuts to USAID have been more on our radar screen through the media, but we some of these other donors have been making cuts in commitments that are similar in scale. And we're anticipating that in the UK, this is likely to come down a little bit further in future years. Germany has also cut its spending for development assistance down now to about 2.3 billion this year. That's expected to decline a little bit further next year and the further year. France, as you see here, has cut spending from levels in 2023 by almost half, and they're best as we can tell, those levels are likely to be sustained for the next couple of years. Canada has also made cuts, and as you know, the Carney budget just got approved, and in that document, I believe the figure was 2.7 billion Canadian to be cut from development assistance, spread over the next 4 years. Now that's over all areas of development, not just global health. But we're seeing again some decline in spending from Canada. Now the one outlier in this picture is the Gates Foundation, and as you may have heard, Gates made a decision a number of months back that they're going to spend down their endowment over a period of 20 years. So they're accelerating their spend, and that's resulted in a bit of an increase in their commitment to spending in global health. But that's even in 2025 now. Gates Foundation now emerges as the biggest donor in this space, and then that continues on. That's expected to continue on into future years. Okay, so what this, there we were looking at sources, and here we're looking at some of the things that the donors have been putting their money in, and I've included here, 3 kind of UN agencies, and then this kind of multilateral funding initiative, the Global Fund. And from last year to this year, all of these global level entities have taken like quite a big hit. Like we're seeing here that WHO's budget has dropped by 3/4 over that period. I was chatting with a friend of mine who was talking with colleagues at the WHO, this morning. He told me that WHO has cut 1/3 of the WHO Geneva has cut 1/3 of their staff. But similarly, for other UN agencies in Geneva and other international organizations, there have been massive layoffs. So he was telling me that there's been 30,000 jobs cut in Geneva. So this is affecting not only global health, but development and diplomacy. These other entities, the World Food Program and the Global Fund, have also sustained quite big hits. And World Food Program is one of the most, perhaps the most important entity out there for famine response. So when you see a big cut in funding, I mean that means that the world community is not in as good a position to be able to respond in the face of famine. Okay. Yeah, the other thing is in June, RFK Jr. announced that the US government would rescind its previous pledge to Gavi, the vaccine initiative. So there had been a commitment under the previous government, under Biden, to this year to put in an extra 300 million. And then over the next 5 years, there's a commitment of 1.6 billion for Gavi, but all of that was zeroed out. So the current year's contribution to Gavi has been completely zeroed out, and RFK Jr. Specified that next year there won't be any funding for Gavi either. So for those entities and for others, the way they're funded, I mean, every couple of years there are kind of new multi-year funding commitments from the big donors, and these are called replenishments. And so this year, for several of these agencies, they've kind of come up on a replenishment period. So now for the Global Fund, with the cuts that are, or with the failure of donors to make commitments to maintain their level of funding, the estimates are that there could be 1 million more malaria deaths over the next 5 years. I mean, so currently there's about 600,000 malaria deaths per year, but we could see that increase to about 800,000 per year. Most of those deaths are among children under 5. The Global Fund provides about 2/3 of all international funds for fighting malaria. I mean, the other big donor in this space has been the US government with the President's Malaria Initiative. Now, the Global Fund is, they're convening their funders next week, and they've targeted $18 billion for their operating budget for the next 3 years. But based on the signals that we've had from these big national donors, it appears they're not going to reach that target by a long shot. And I mean, as I believe I mentioned before, the White House has also specified that there will be 0 new commitments in funding for the Global Fund, and the U.S. government has been the biggest source. I mean, U.S. government had been the biggest source for WHO as well, and again they've zeroed out funding to WHO. Germany, last month, Germany committed $1 billion to the Global Fund, but that was 23% less than its previous commitment. Last week, Britain announced a 15% cut in its contribution. So down to $1.1 billion from previous level of funding at $1.3 billion. So the current estimates of the impact of these funding declines at the Global Fund are about 250,000 excess deaths each year moving forward. Now, Gavi, I mentioned that the U.S. government has zeroed out its funding for Gavi. Britain has been the biggest funder for Gavi, accounting for about 1/4 of its budget. And it now appears that Britain is cutting its contribution for over the next 3 years to Gavi by 40%. So Gavi is also facing a funding crisis. Now, here I've got kind of laid out what the funding picture looks like across different program areas 2 years ago and then this year. And again, bearing in mind that we're expecting to see further shrinkage in these numbers next year. So the other category here, by the way, down at the bottom, this includes neglected tropical diseases, non-communicable diseases, health systems, epidemic preparedness, and and other areas. And then the others above these are the the bigger program areas. What I've labeled here, child health. This is child and newborn health, and it includes also nutrition and immunization. And of these program areas, this has been the least affected, like so at least over this 2-year period. So you see that there's been a decline from 7.9 to 7.6 billion. But with those cuts beginning next year to Global Fund and Gavi, then we're going to start to see a significant bite for child health. For what I have here is maternal health and family planning or reproductive health. That's down 22%. You see here from 5.9 to 4.6. The biggest cuts proportionately here are for TB with a decline of 29%, malaria with a 33%, a 1/3 reduction over this 2-year period. And then the biggest cut has been HIV. Now, this reflects the fact that the U.S. government is far and away the biggest contributor to that program area. So a little more on the HIV funding cuts. On the left here, I'm showing this is a map showing countries in the southern cone of Africa by HIV prevalence. So all of the countries in the world that have an HIV prevalence of 7% or more are in this region, in the southern cone. And so we see the highest rates in Eswatini at over 20%, and then after that, Lesotho, Botswana, South Africa, Mozambique, Zimbabwe, Namibia, Zambia, and Malawi. Now on the right, I'm showing the World Bank income per capita categories, and so we see here is in the region there's a mix of economies, including 2 countries here, South Africa and Botswana, that are classified as upper middle income countries. And then we have several others that are lower middle income. And then of those with high HIV prevalence, it's Mozambique and Malawi that fall in the low income country category. Now, together, these countries in the southern cone of Africa account for about half of all prevalent HIV cases in the world. Elsewhere in Africa, countries that have 1 million or more prevalent cases include Nigeria with about 2 million, Tanzania, Kenya, and Uganda. Now, of those, Uganda is classified as a low-income country, and then the other 3 are classified as lower middle-income countries. So if we add those 4 countries to those in the southern cone, now we're up to about 2/3 of all prevalent HIV cases. And the 3, I guess it's the 2 upper middle income countries in the southern cone. In those countries, 60 to 80% of the cost for HIV treatment is met from domestic sources, mainly from government. So arguably, these countries have the fiscal space to make up for the gap created by cuts to American support for these programs. But elsewhere in Africa, that's not going to be possible over the short to medium term. So if those living with HIV are to receive treatment, there will need to be external funding support. And by the way, elsewhere in the world, the three countries with 1 million or more prevalent cases are India with 2.5 million, the US, Russia, and Brazil. And both India and Brazil have been receiving some funding from US government for HIV. So moving beyond HIV, well, first of all, because of the cost and complexity of HIV treatment, it's not only low-income countries that will struggle to maintain these services. Middle-income countries, especially lower middle-income countries, will continue to need at least some external support to continue providing these services. But beyond HIV, how are countries going to be able to cope with these funding cuts? Here, what we're seeing is a little over 20 years of evolution in healthcare spending by economic category, by World Bank economic categories. And we've got three big categories. We've got out-of-pocket expenditure for healthcare. We've got external, like that's kind of donor support, and domestic funding. And over this period, there are two notable changes. First, what we see, okay, I'll start with the low-income countries. So in low-income countries, over this period, we see a fairly marked increase in the proportion of total healthcare funding that's coming from like external or donor support. So at the beginning of this period, we're looking at maybe about 12%. And then by 2022, up to about 30% of all healthcare spending coming from external sources. So that's in low-income countries. Now, with that, there's been some relative decline in domestic government spending, but these are low-income countries. There's been a little bit of a decline in out-of-pocket spending, which is good because out-of-pocket spending ends up being a barrier that prevents people from seeking care. Lower middle income countries, somewhat different picture. One thing is that we have a pretty steady rate of external support, like in the range of, say 5 to 7% over that 20-year period. So, I mean, the good news here is that this external support has been particularly concentrated or focused on the low income countries, whereas in the lower middle income, because again, they have more fiscal space, there's more capacity for them to support their own programs from domestic resources. And we've seen over that period an increase in domestic government spending in these countries and a decline in out-of-pocket spending, which is what we would want to see in those countries. In upper middle income countries, like South Africa and Botswana, external doesn't really feature. Now, this is all upper middle income countries across the world. So there would be, at least a few percent of healthcare expenditure in South Africa, Botswana, Namibia, from external sources for HIV. But the overall picture in upper middle income countries is that there's negligible contribution from external funding. And we've also seen an encouraging rise in domestic government spending for health and a corresponding decline in out-of-pocket. So, I mean, overall, this is kind of the picture that we would like to see, like where the resources are particularly focused on the lowest income countries, those that are able or that are better able to support services from domestic resources in general have been relying much more heavily on domestic resources than external funding. So that was the picture, again, over this period ending during the COVID pandemic. So with the funding cuts that I've been talking about, now the question is kind of which countries are likely to be most affected. So here we've got, this is kind of blowing up. I showed you before the picture for the southern cone of Africa. Yeah, that's what I figured. I had a different map here. So for 2024, upper middle income countries included Namibia. I guess the other one I showed you was 2023. So here what we see is that the low income countries are particularly concentrated in, you could say, equatorial Africa. Plus we have, a few other countries in Asia and the Middle East, Afghanistan, Syria, Yemen, North Korea. And then, so those are the countries that are the least well positioned to be able to, for domestic resources to be able to fill the gap with declining development assistance. So what we're looking at is development assistance for health. So this is donor support to health programs, external support to health programs per capita. And this, well, we see a concentration. Well, I should point out here that, where are we now? So what I've included here, okay, so all countries where donor assistance is less than $14 per capita, I have marked in gray. So the ones that that are marked in blue, it's $14 or more per capita, and the ones with the lightest color are actually those that are receiving the largest amounts per capita. And you see, there's most of them are in Africa, but we have a smattering of countries across other regions that have been more heavily dependent on donor funding. So New Guinea, Laos, Bhutan, Afghanistan, Ukraine, and then several in the Caribbean region. Now the countries that are most heavily dependent are Eswatini and Lesotho, where external funding support is in the range of $80 to $100 per capita. And this reflects the fact that they have very high HIV prevalence and are dependent almost exclusively on external support for HIV programs. The funding support in Botswana is, Botswana is about 60 per capita. And then in Botswana, Zimbabwe, Zambia, Malawi, Mozambique, where much of the funding is for HIV treatment, external funding is in the range of $35 to $40 per capita. So other African countries with comparatively high external funding include South Sudan at over $50 per capita, the Central African Republic at 40, and then Sierra Leone and Liberia and Rwanda at about $25 or $30. Now, also in the 35 to 40 per capita range, but outside of the Africa region, are Afghanistan, Haiti, Belize, and Suriname. And then we have, so in Ukraine, it was $24 per capita. So anyway, I won't go through all of those. But you see that we have a number of countries here, including low-income countries, where there's been comparatively large amounts of health development funding kind of calculated on a per capita basis. So here what I'm showing is countries where the total received for of external funding for health is more than what the government is spending from their own resources. So all of those that are colored in anything but gray here, there's more money spent on health and health services coming from the donors than there is coming from domestic government resources. And here, those with the highest ratios are Afghanistan, South Sudan, and Somalia, where in the case of Afghanistan, external funding, there's 30 times as much spent on health by external donors as there is by domestic government. And then in South Sudan and Somalia, 18 times as much and 15 times as much. Now, all of this was before this year's funding cuts. And the other thing is that of health development spending in Africa, 2/3 of that, up until recently, 2/3 of that was from the U.S. government. So Africa has been much more heavily dependent on American funding support specifically. So you see, there's a number of other countries here, Yemen and Central African Republic have a very high ratio of external spending to domestic spending. There's a few others here as well. So any of these countries that have, like, where external support, and again in the case of Africa, this is external support largely from the United States, like where that's multiple times higher than domestic government spending on health. I mean, clearly, like the domestic government just they don't have the fiscal space. They don't have the resources available where they can come anywhere near making up for the gap in funding. Yeah, so before the recent funding cuts, I mean, Malawi, which is a low-income country, health development funding just from the US alone was more than double domestic government spending on health. And in Liberia, Uganda, and Mozambique, external support just from the US was approximately at the same level as the domestic government spending. So those are like 4 countries that have been extremely dependent on US government spending and are now like facing very, very difficult challenges. Now, not shown on this map is Haiti, where external support for health is 7.5 times higher than domestic government spending. So there's some countries outside of this region. Okay. So as we've seen, the most heavily affected countries are going to be low-income countries that are heavily dependent on external health development funding. Also heavily affected are going to be people who are living with HIV whose treatment has been paid for in the past by the U.S. government. And finally, there are other conditions which we've already looked at, like malaria and tuberculosis, and those program areas have been heavily, I would say, donor dependent. So with cuts to these entities like the Global Fund, those program areas are going to take a big hit. And again, the countries most affected, like for malaria, it's Mozambique, Burkina Faso, Mali, and Central African Republic are going to be most affected. And these are all low-income countries with high malaria mortality burden. And with cuts to the Global Fund and the US government funded President's Malaria Initiative, we could see between 500,000 and 1 million more malaria deaths each year. But of those, 500,000 to 1 million deaths, it's especially going to be these high malaria burden, low-income countries where we're going to see the greatest impact. For tuberculosis, Mozambique and Central African Republic have exceptionally high mortality rates and very limited domestic resources. So in these and other countries that have been heavily dependent on US government funding for their TB programs, it's been estimated that without restoration of this funding, there will be over 2 million excess TB deaths over the next 5 years. For acute malnutrition, it's estimated that in recent years, between 350,000 and 600,000 deaths among children under 5 have been averted each year due to programs that are targeting acute malnutrition. Specifically programs that have been supported by the US government. So with continuing suspension of this support, like to the Global Fund and to UNICEF, countries with very high rates of acute child malnutrition are likely to struggle to respond to that gap. So this, I mean, at the very end, I've got a kind of a list of resources for anybody who wants to kind of follow up and dig in a little bit more deeply. But this is one of the useful resources out there, impactcounter.com. This is tracking, based on the best modeling we can do, specifically the results of cuts to US government funding. And so just since the beginning of this year, almost certainly we've had over 100,000 excess HIV deaths, just as a result of US government funding cuts. And this website includes HIV as well as child deaths, TB, malaria, and others. And based on conservative assumptions, these funding cuts are currently resulting in 88 deaths per hour. And 2/3 of these deaths are among children under 5. Most of the adult deaths are due to HIV and TB. Now, this modeling can be challenging, particularly for HIV. Under the US government support for HIV treatment, they had quite robust data systems, for tracking patients under care, and there are lots of key program performance indicators that were being tracked. But this has been, those information systems, those data systems have been completely shut down. And what, for me, it calls to mind is Mao's Great Leap Forward. Now, this was when I was a toddler. It was back in the late 50s and early 60s when Mao shut down mortality reporting in China during that period. And it's estimated that there were tens of millions of excess deaths during that period, but they weren't being counted. And again, it seems that seems to be a somewhat similar mentality in the White House now. So if we can't count it, it's not happening. And as I pointed out, this is just showing modeled effects of cuts in U.S. government funding. It doesn't reflect cuts from the other major donors. So these are like the immediate or short-term effects, but what about longer term? Now, here I'm going to introduce a couple of books that I'd recommend. This one is by a colleague of mine who's he's a social scientist who's worked, his career has been with the World Bank. Michael Woolcock, well, first of all, he defines development as history in a hurry. So this is, meaning intentional efforts to grow the economy and improve living conditions, notably to reduce poverty. And then he breaks this down into 3 types. So national development, he defines as an historical, geopolitical process presided over or led by national governments. Big development, he defines as professionalized technical assistance supported by UN agencies, development banks, bilateral donors, and major foundations. And global health tends to be equated with this category. And then he uses the term small development to refer to more localized, customized efforts undertaken by domestic charities, faith communities, advocacy groups, other NGOs. So what we're seeing at the moment is a really big hit in big development. And I don't think there's any reason to believe that this is just going to be a one-off where it's just going to be a blip where for 1 year we see a reduction. I think we've really reached a turning point. So now, I can point out here that the donors are big players in this space, but then we also have the big UN technical agencies like WHO, UNICEF, World Food Program, UNFPA, also major international NGOs and university-based players. And so their activities in global health, to a large extent, they've been funded through, these, from these big donors. So this whole sector, the big development, sector providing technical assistance for global health. I mean, I think what we're seeing right now is that portion of the global health picture is fading quickly. Now, one of the problems with the arrangement, like with the role that these players have had, is that the priorities have ended up being determined at global level, and by actors, well, often with standardized targets and standardized strategies. And this reflects the fact that you've got certain players in the picture with deep pockets, like you've got World Bank, these big bilateral donors, and then you've got national governments that have like much more modest budgets. So you have power asymmetries based on the money that the different actors are bringing to the table. So, but we appear to be at a time in history now where big development, at least as related to health, has pretty suddenly begun to fade in importance. So I really do think that this is an important inflection point, and there's an opportunity there, I think, for new paradigms to emerge, and for previously kind of neo-colonial relationships to be replaced by something that in important ways is better. Here's another book I'm recommending. This is by a public health historian at Johns Hopkins, Randall Packard. And this book mostly focuses on kind of how the global health field has evolved over the last century or so. And over that period, like it's changed its names a number of times, like missionary medicine and then international health, global health. But he proposes that over that period that there have been two competing paradigms. And the first one has been in the ascendant for the last 40 years. Now, this disease control paradigm, it's been embraced by the big donors like USAID and Gates Foundation, as well as by the UN agencies and international NGOs. And this paradigm, it's based on the idea that where you've got limited resources available, you want to spend them in the most efficient way possible, where you can get the greatest benefit. And so, first of all, the idea is that you identify like what are the conditions with the greatest disease burden, like that are contributing the most to preventable mortality. Then for those causes of death, then you identify the like efficacious interventions that can be delivered where it's feasible to deliver them and where it's cost effective to deliver them. Then the efforts are concentrated to try to ensure the highest possible population coverage for those interventions, so that you're achieving maximum impact. Now, this has also meant that the delivery modalities have tended to be kind of verticalized. Like so rather than trying to develop broadly develop health systems, there's been a focus on just making sure that the delivery mechanisms for these specific interventions is functional. Now, there is good evidence that this approach has saved millions of lives. So we can't we have to give credit for that. But there are important problems with it. Now, arguably, this arrangement where priorities are dictated by donors and by global level players like WHO, this perpetuates an asymmetrical neo-colonial distribution of power. And furthermore, like at country level, this kind of prioritization, like where the priorities are dictated like from global level, it doesn't necessarily correspond to what the situation on the ground is. So for example, HIV, there's been comparatively like a lot of money available for that. So even in countries that have comparatively low HIV prevalence, there's millions of dollars of funding that will come in, and including in countries where there are other kind of pressing disease priorities or contributions to disease burden, which may account for a lot more deaths than HIV, but because they're not on this very, very narrow list of program areas that are supported by donors, then they don't get external funding. I mean, I think as most of you are aware, non-communicable diseases are by no means limited to high-income countries, and we're seeing in most low and lower middle income countries that non-communicable diseases are now account for a very large proportion of disease burden. But there's relatively little development assistance for health spending on those priorities. So there's an arbitrariness, or there can be an arbitrariness in determining what priorities to pursue. Where the priorities, the priority areas that are supported aren't necessarily those where there's the greatest disease burden. Now, looking forward, I mean, none of us have crystal balls that I'm aware of, and so it's hard to reliably predict how things are going to be unfold. But I think I feel pretty confident to say that we are at a point in history where the paradigm is likely to shift. And we're starting to see, just over the last month or two, we're seeing various lower middle income countries stepping forward with new commitments, kind of closing gaps created by the withdrawal of support from the traditional funders. So in September, at the UN General Assembly, the president of Ghana, John Mahama, launched what's called the Accra Reset, and it calls for initiatives led by the Global South for realizing the vision of equitable partnerships, shifting from being passive recipients to being active negotiators, country-led, investment-driven health systems powered by domestic resources, private sector engagement and philanthropic partnerships, and defining priorities within countries in the global health, not dictated, from Geneva or London or Washington. So are we facing a crisis or an opportunity? Well, I think pretty clearly from some of the figures I was showing you earlier on, like in a number of the most affected countries, with the least resources to draw on, and where there's very heavy disease burden from like HIV, TB, malaria, that this is certainly a crisis that they're facing. And at the same time, though, I think there is an opportunity. Like there's the possibility in the coming years we're gonna look back at this time as a moment where there was an important pivot, and where in important ways we moved to a better place than where we had been before. Now, how this is all going to work out, like it depends very much on the country, and certainly in those countries with very high HIV prevalence or high burden of some of these other conditions, and without the fiscal space to respond, they're certainly going to be struggling over the next couple of years. And some of them, I've mentioned them already, countries like Malawi, Mozambique. It's urgent that there's response, and that there's at least some restoration of the funding that's been withdrawn. Now, at this point, like there are, as I showed in an earlier slide, it's not only U.S. government, but the other major European donors have signaled their intent to cut back on their funding commitments. Now, at the same time, there are lower middle income countries that have at least some fiscal maneuvering room. I mean, one example would be Nigeria. And now is certainly the time for significant new commitments of domestic government resources. For the low-income countries and a few particularly vulnerable lower middle-income countries, this is going to be more difficult. But again, I think the Accra Reset, expresses some important principles, and it signals a recognition that that domestic governments are going to have to take leadership. Now, at least some of you, I expect, are kind of thinking about how would you be engaged in global health, like kind of moving forward in your careers. as I mentioned, I think that the big development portion here, like this is radically shrinking. So I think opportunities to be working full time in this space, like to pursue a career, they're going to be, it's not that they're going to altogether disappear, but there's going to be a lot fewer opportunities than there has been in the past. Um, and there are like hundreds of thousands, or maybe even in the millions of people who've lost their jobs just over the last 8 or 10 months. Most of them are in low and lower middle income countries. I mean, I mentioned that there's 30,000 people who've lost their jobs in Geneva. I mean, there's probably a similar number, or probably a larger number in Washington and Baltimore. But the larger number would be in countries that have been recipients of this support. Um, that having been said, like the needs haven't suddenly disappeared, and so services and programs need to continue, and they efforts need to be made to ensure that these programs are as effective as they can possibly be. Um, if you'll remember an early slide, I showed that like by 2 years ago, we were back to the same overall level of funding as we were in 2019, but then the current year is down by 20-25%. It's likely to go down somewhat further, but still the overall funding in global health, it's greater than it was 15 or 20 years ago. So it's not nothing. And so I think there is going to continue to be like some significant like external support for global health, and there's going to be a need for people working in this space, like pursuing careers in this space. Um, at the same time, um, um, I think there's plenty of opportunities for us to be engaging with colleagues or counterparts in other countries, and kind of bringing our expertise to the table, but in a spirit of reciprocity and mutual learning. So I think there's still going to be plenty of opportunities for partnership, and I think where the power differentials resulting from like certain partners bringing so much money to the table, where we're not going to be seeing as much of that in the future, then I think that's going to favor more of a true spirit of partnership. I do think that this is going to very much accelerate movement away from neocolonial approaches and neocolonial power relationships. So in that sense, I think we'll be moving to a place where I think there's going to be more mutual respect as we're engaging with partners in other countries. I mean, another point too is that we have a lot of people living in Canada who are members of diaspora communities, and they may be very much focused in their day job on work in Canada, but at the same time concerned about how things are going in their countries of origin. And there are lots of examples of networks of people working networks of people in the diaspora continuing to be engaged and supporting and helping out back in the countries that they came from. So I would say that there will be opportunities. It's going to be it's kind of a different world that we're moving into. But I mean, like for those that kind of have an interest and a passion in global health, I think there are going to continue to be opportunities. Although again, it's going to be on a new basis. Now, my last slide here is a kind of a bunch of resources that if you'd like to dig in kind of on these questions about what's happening with funding. So anyway, so I've left the slide deck with Patricia so she can make that available to whoever's interested. So that's all for me.